Gynecological cancer is it's a cancer which involves the reproductive organs of born female, such as cancer of the uterus, which is the womb, ovaries, fallopian tubes, cervix, vagina, and vulva. There is also peritoneal cancer, which is the cancer of the lining of her abdomen. It's because it is similar to the cancer of the tube and ovaries. It is also included in gynecological cancer. There are different types of gynecological cancer. Again, it depends what tumor type they are, but also depends which organ they start from. The commonest of gynecological cancer is uterine cancer. Around 1 in 41 women in UK will get gynecological cancer in lifetime. And there are approximately 10,000 new uterine cancers being diagnosed in UK every year. And the second type of cancer is ovarian cancer, then tubal cancer, cervical cancer, and the rare cancers are the vulval cancer, the vaginal cancer, and the peritoneal cancer. So again, because they have different tumor types, they can present differently, they can behave differently, and they present in a different age group. Now, when the cancer arises from one of these organs directly, it's called primary gynecological cancer. However, there are cancers which can arise from other organs, and they can cause disease in gynecological organs, and these are called secondary cancers. For example, sometimes a patient may have a breast cancer. In an unfortunate advanced diseases, they can be metastasis, which is distant spread of the cancer on the ovaries, and which is called secondary cancer. There is also 10% of females' cancers can be familial. That means they may have the genetic, they may carry the gene which predisposes them to have gynecological cancer. And the well-known is the BRCA1 and BRCA2 gene, in which women who carry this gene are at risk of developing ovarian cancer and breast cancer. There is also other type of genetic cancer called Lynch syndrome, where women who have this kind of gene are at risk of developing ovarian cancer, and mainly uterine cancer, breast cancer, bowel cancer, pancreatic cancer, and all these can predispose, this gene can predispose them to have any of this cancer. And what actually causes these cancer? If we go back to reason why anybody gets cancer, 1 in 2 people nowadays would unfortunately get cancer of some sort. In the past, it used to be 1 in 3, but now the incidence is 1 in 2. There are the basic, what we call as etiology reason for cancer is our human body has got cells, and they replace every 7 to 10 days. We don't actually see that. Even our skin will shed, and the same thing happens in any part of our body. And we all carry a gene called a tumor suppressor gene, which makes sure these cells are replaced by normal cells. But unfortunately, sometimes some abnormality happens in this gene, whereas these cells are unchecked, therefore they produce abnormality. And this is called a mutation, sometimes happen in gene, which sometimes, as I said, can be genetic, but there are other factors which predisposes a person to develop this cancer. And the few which we know, and obviously we don't know all causes of cancer, but certainly the ones which we know can cause abnormality in this tumor suppressor gene are such as increasing age. Unfortunately, as we get older, our risk of cancer increases. Smoking, if we smoke, it is certainly a significant risk factor for cancer. We know it can cause lung cancer, but in gynae causes especially cervical cancer, or is one of the etiological factors of cervical cancer. If a woman takes unopposed estrogen, that means only estrogen, especially when she has a womb, she's at risk of developing uterine cancer. With increasing age and also increasing weight, so we have high BMI patients, they are significantly at risk of developing endometrial cancer, which is cancer of the womb. And certainly there are some possibly dietary factors, alcohol, but these are the common ones. And cervical cancer, we know HPV is a significant risk factor for cervical cancer. Having said that, not necessarily all women who may be HPV positive develop cancer, but knowing this is a risk factor, we have a very successful screening program where women can be screened for HPV, and if that was positive, then they can have a further test called colposcopy, which can diagnose the very early pre-cancer stages of cancer for cervix, and that can be very easily treated. The symptoms of gynecological cancer are very variable, depends upon which organ might be involved, and they can be very subtle, such as irregular bleeding, heavy periods. This can be a sign of uterine cancer, or you can have bleeding after intercourse, or pain after intercourse, which is unexplained. Certainly, the certain age group which are at risk of the cervical cancer can be a sign of cervical cancer. Although hopefully we are hoping that with the screening program now in place, we will see few of those patients. But other signs of, for example, vulval cancer, which is rare, but there are patients who especially have vulval dystrophies, such as called lichen sclerosis, that they may have chronic vulval itching and they may have vulval lump, therefore that may be a sign of early vulval cancer. And if there's, for ovarian cancer, which is unfortunately diagnosed at a late stage, the signs can be very non-specific, but certainly bloating, which you can't explain, or altered bowel habits, which you can't explain, feeling full, or having discomfort in the pelvis, they can be signs. I mean, the problem with, because unfortunately females are normally have symptoms around their periods, they are thought to be, they get confused, but is my normal period, or is it just a bit of an irregular period? And then there's always change happens around the perimenopause, periods become irregular anyway, but at the same time, they can be having symptoms of cancer, so they can overlap those. But certainly for endometrial cancer, postmenopausal bleeding, it is not normal to have postmenopausal bleeding, but that could be a sign of cancer. Having said that, significant number of these women do not have cancer, but will need to be seen. So these are the really common symptoms of gynecological cancer. For any cancer, the treatment really depends upon, and the success of the treatment depends upon the stage of the disease. Every cancer has got 4 stages, and stage 1 being the earliest one. And if the cancer is diagnosed and treated at early stage, there is a significantly better outcome for the patient as compared for a late diagnosis and treatment. So for cancer treatments, we talk about 5-year survivals. For example, for ovaries, 5-year survival is around 46%, unfortunately, which is not as high, although it's getting better. But that's, again, because the presentation usually is late. Unfortunately, ovarian cancer still is diagnosed at around stage 3, stage 4. That's because patients beforehand have very, very non-specific symptoms. Whereas for cancer of the womb, which is a uterine cancer, the 5-year survival can be up to the overall 5-year survival is around 80%. However, if we diagnose it, which commonly we should diagnose it, patients come forward at a very early stage 1, and therefore their 5-year survival is very, very good. And again, overall survival for cervical cancer is approximately 67–68%, because we're taking all stages. However, for stage 1, the survival is very good, and especially if women go through a screening program and have pre-cancer cells treated and they are abnormal, then we have significantly reduced risk of cervical cancer for these women. And for vulval and vaginal cancer, again, very rare, but the 5-year survival is around 64–65%. So really, the success rate of gynaecological cancer, as with any other cancer, is early diagnosis. And one of the best assessment could be that many gynecological presentations can be really easily diagnosed, especially uterine cancer, cervical cancer, vulval vaginal cancer, because a simple gynecological examination will pick up an abnormality. Gynecological cancer, because it involves all different organs and they are different types of cancer, so the common, there can be one or multiple treatment modalities used to treat gynae cancer, such as surgery, chemotherapy, radiotherapy, or hormonal treatment. It all depends on what type of cancer they have and what stage a woman has presented. The commonest cancer is the uterine cancer, and for those, surgery is usually the best treatment as compared to radiotherapy and hormonal treatment. But again, it will depend upon what other comorbidities patient has, whether is she able to have surgery, has she got any loss of medical problems. But surgery commonly for uterine cancer, what we do is pelvic clearance. That means removing the uterus, neck of the womb, tubes and ovaries, and other biopsies which are relevant. And nowadays we do them as keyhole surgery so the patients can recover better. So for example, I use both laparoscopic treatment or robotic treatment for these women, and many of these unfortunately will have high BMI. So the robotic hysterectomies for these patients are shown to be really beneficial for the patient because we can perform the operation, we can complete the operation as minimal access, they can recover better, and the further treatment if needed, such as radiotherapy, and very occasionally may need chemotherapy depending upon the tumor type, they can recover better from robotic surgery. And for early cancers, otherwise, for example, cervix, as I said, the pre-cancer treatment is really done surgically beforehand. But again, what type of cancer treatment we give a patient, it all depends, having a good assessment of the patient and reviewing all their history, their examination, their investigations, their histology type in a multidisciplinary group meeting, so that we can decide what's the best treatment option for the patient. And obviously you take patients' views into consideration and their other comorbidities to decide what is the best form of treatment for them. Surgery is the main treatment for uterine cancer, which especially at an early stage by undertaking hysterectomy, both by laparoscopy or by robotics. For cervical cancer, again, early stage cancer, again, they are treated surgically, but in pre-cancer, we treat them by simple outpatient treatment by removing the small area which has got pre-cancer area and conserving infertilities. For vulval cancer, again, early stages, we can remove the area surgically. Ovarian cancers, again, depends upon diagnosis. If surgery can be done, the best form is done by surgery, but then the majority of them will require adjuvant chemotherapy. And sometimes in advanced cancers, again, as I said, it's a multidisciplinary discussion. What happens sometimes, they may have chemotherapy first before they have debulking surgery. It will all depend upon the result of their investigation and the MDT discussion, discussing with oncologist and whole team to see what best form of treatment is for the patient. Rapid diagnosis is early diagnosis. This has been my passion for years. I was one of the first 20 years ago who set up a rapid diagnosis clinic. And part of that diagnosis really is education of the patients and education of the GPs, so that they can recognize what are the abnormal symptoms and empowering patients with the information, with the knowledge that which symptom is normal, which symptom is abnormal, and not accepting that, oh, this is your perimenopause or this is your heavy period. Because even those situations, patients really should be managed in this day and age. As a female, they should not be suffering because they have a period, heavy period, or they have menopausal symptoms. So significant part of the rapid diagnosis, as I said, is the education of the patient and their referral GPs. Then setting up a service, because as I said before, majority, because the gynaecological organs are accessible by simple gynecological examination, but also needs to be done by experienced gynecologists who know exactly what they're looking for. For example, cancer of the womb, I can easily diagnose that by simple ultrasound, but we'd measure the lining of the womb, and then if it's increased, we just do a simple outpatient biopsy, and almost 90% time we will get diagnosis by just one appointment patient coming to the clinic. And same with ovarian cancer, we can assess depending as an ultrasound, a blood test, and age, and putting all these together, we assess what we call the risk of ovarian cancer, and we can either do further investigations, or we can reassure the patient, or we can, if they present with ovarian cyst, for example, 80% of ovarian cysts are benign. If they're causing symptoms to the patients, we can treat that surgically simply by keyhole. And same if there's a vulval lesion, we can do an outpatient biopsy. So yeah, it's a whole process. I think it's having education of the patient, education of GPs, education of the whole team who are helping with those, then having a setup with the histopathologist diagnostic team. And we can do all that in one setting, so that patients are diagnosed with cancer as soon as possible. But equally, the most important thing is 90% of the patients who have been referred as suspected gynae cancer symptoms do not have cancer. But they are equally worried because they think they may have cancer, they may have these symptoms, which is important. They have come forward with those symptoms, but unless we do the assessment, do the diagnosis, do the relevant tests, we will not know whether they have cancer or not. But doing it rapidly, and then also reassuring those 90% of women that they don't have cancer, but equally then providing the treatment what they require, is a part of the rapid diagnosis service, which I do provide routinely in all my clinics.